Yeah, so I'm the medical director of infection control at St. Michael's, and as was alluded to, I'm in the background as a potential person that can help because Alison McGeer is away, although Wayne and his team have been doing a superb job, so I haven't been called in too much to do anything up to this point. So I really just wanted to talk to you a little bit about background information on Ebola, and Howard, you can correct me if I'm going off on the wrong tangents or you wanted to hear something different, and I'll definitely leave some room for questions and discussion. So I was going to start off just with the basic clinical picture of what is Ebola. So, it's a filovirus. It's a severe viral illness that causes a multi-system illness with a high morbidity and mortality. Although in the past, the vast majority of cases, and actually still the vast majority of cases, have been treated in Africa. But for the first time, we've had some limited exposure to cases in the US that's actually shed some light on the clinical picture with Ebola. So in Africa, the mortality in outbreaks often ranges from about 50 to 90%, which is one of the reasons this is such a fearful kind of disease. But there's some data emerging from the US that we can do better than that with modern healthcare, and that a lot of the problems with Ebola are basic things like fluid and electrolyte imbalances that are difficult to correct in the absence of being able to get blood work and IVs and modern medical therapy. So that's a little background. In terms of the clinical features, usually it starts with a sudden onset of headache and severe malaise and myalgia and fever. So in many ways, sounding like the flu and many other illnesses. And we actually have heard of instances where healthcare workers in Africa have worked for 5 days after they've developed Ebola. So often for the larger part of the first week, you're kind of like an ambulatory patient who's feeling pretty crappy, but if there's a lot of pressure on you, you might still be going about some of your normal activities. And then after this initial phase, there's a variety of other symptoms. So the main thing is fever. The vast majority of people do have fever. And then again, headache, malaise, myalgias, and these type of non-specific symptoms. And then there's a few other things. Some people get conjunctivitis, some people have cough. And then after that, people appear to go into a GI phase of the illness, which is actually, I think, was under-recognized in the past and was really noticed in these US cases. That's almost like a cholera type of illness with severe diarrhea for 4 or 5 days, and somewhere in there, usually a couple days of severe vomiting. And in that phase, people have extremely low potassium, magnesium. And so some of the US healthcare workers, if you saw them when they were transferred to the US and they walked off the plane, they actually looked pretty good. By the time they got to Emory and to Nebraska, they actually had severe electrolyte imbalances and were having arrhythmias. So they looked okay, but they were close to a very preventable death. And then following the GI phase, people go into more of a septic shock phase and then either recover or die. And there's some hope that might be more like a 20% mortality in people that are cared for in modern medical facilities. So that's a picture of the clinical illness. In terms of the epidemiology, the basic epidemiology, you've probably heard this before, but the incubation period is 2 to 21 days. 21 days is being pretty cautious, so the vast majority of people present about 5 to 10 days after the onset of illness. It's not transmissible before you have symptoms, and these are two key things. So the fact that the incubation period is fairly long and that you're not transmissible before symptoms really makes this totally a different paradigm than when you're dealing with flu. So flu is transmissible before you realize that you're sick, and the incubation period can be as short as 24 hours. So by the time you find a flu case in a country, in a facility, or anywhere else, it already could be 2 or 3 generations of spread going on, and with exponential increases, you can have explosive flu outbreaks in long-term care facilities where 40% of the facility has flu within a week or two, and they can be very hard to contain, which is why we do things like vaccinate everybody in those facilities. If there's as soon as you recognize 1 or 2 cases that might be an outbreak, you put everybody on Tamiflu. You really have to act quickly. So in Africa, when you get 1 Ebola case or 2 Ebola cases, there probably are, you may not have picked up everybody, but it then expands slowly. So it's a week or 2 later that it doubles, and it has a more of a slow pace to it. And then again, the really important part is that they are not infectious before they have symptoms. So in terms of contact tracing, you just have to figure out when they were sick and follow people from that point. So the second thing that happens is that as soon as you are sick, you are infectious, but that infectivity is likely very low, and it's spread entirely through contact with blood or body fluids. So when the first moment that you have fever, we have to assume that you're now infectious, but it's a very low level infectivity. And then as your viral load increases and your clinical illness increases, that's when the risk starts to really increase. So you have increasing viral load in the blood, And at the same time, you start to have the vomiting and the diarrhea, which is about a week until the illness. Usually it's different in different people. That's when you're going to heavily contaminate your environment and everything around you with the blood and body fluids, which are highly packed with the Ebola virus, and that's where the risk of transmission is. So this is why, to a certain extent, it's a higher risk for healthcare workers caring for the sickest patients. So that's, again, the basic epidemiology. And then to review what the situation is in Africa. So this right now is involving 3 countries, which is Liberia, Sierra Leone, and Guinea. At one point, and those are the really heavily involved countries. So we have 5,000 plus deaths in those countries, 10,000 plus cases, and there's concern that they're missing cases because it's become so hard for them to track. And those outbreaks still appear to be getting worse and worse and worse. From those countries, it spread to Nigeria, where there were somewhere between 10 and 20 cases, and then it was contained in Nigeria, which is actually a huge success story and makes a big difference. And bear in mind that something like a quarter of the African population lives in Nigeria. There's about almost 200 million people in Nigeria. I believe Liberia is about the size of Toronto, so just to put it in perspective in terms of a population. So that would have been a real problem, but it's been more than 42 days since there's been a case in Nigeria. It's now viewed as completely Ebola-free. There was one episode of transmission to Senegal that was also controlled, so there were more cases in the US than in Senegal. That's also now off the map. So nowhere else is involved in Africa, except you may have heard about Mali. And so in Mali, there's been a case, but right now what we need to do with Mali is to monitor Mali and not to worry too much, because I think, like I was saying, we know exactly what happened with this baby who went to Mali. So it will take 8 to 10 days before we might, people are worried that we'll see other cases, but we have a few weeks to evaluate what's happening in Mali. So the best case scenario is there's no other case, just the one, and then we have to wait 42 days before it's officially Ebola-free. But the worst case scenario is, say there's 4 or 5 cases relating to this one case. Those will pop up over this 8 to 10 day period, most likely, some possibly up to 21 days, but usually not. And then by then they may have spread, unfortunately, to other people, may have. But then that will also happen slowly. So if the worst case scenario occurs, and that is like the situation in Liberia, it will still likely be months before they get up to 100 or 200 or 400 cases when there would be any reasonable chance of picking somebody up outside those areas. So again, to put it in perspective, the first case that occurred in the Guinea, Liberia, Sierra Leone cluster was in December 2013. So a lot of people don't realize this. This has actually been going on for 11 months. And mostly it was ignored in the West at the beginning because Ebola outbreaks are not entirely uncommon in Africa, and they usually get 50 people, 70 people, 150 people, and then they're controlled with assistance from Doctors Without Borders or the WHO, and without any transmission outside of Africa. So people were kind of watching but not paying too much attention. And it was only when a couple of healthcare workers were airlifted to the US that the media got involved, and then everybody got anxious about it and then calmed down again, and then there was the situation in Texas. So this has actually been going on for 11 months. It is getting worse in those 3 countries, but it's not something that will happen suddenly overnight in Mali, that there'll be 10,000 cases in Mali. It has to take time, and hopefully now there's already were people from WHO on the ground in Mali to prepare them for this, so they're working in all the countries that are surrounding the 3 involved countries to make sure they're prepared to deal with this. So outside of Africa, there's been approximately, I was trying to count them up, but approximately 28 or 29 patients with Ebola treated outside of Africa. The vast majority of those people were diagnosed with Ebola in Africa, and then they were airlifted back to Germany, Spain, UK, or the US to their home countries for treatment, and ideally to centers that were prepared to receive them. So if a Canadian healthcare worker were to become ill working in Africa, the most likely scenario is that they would develop symptoms there, would be diagnosed with Ebola there, and the plan currently is that they would be airlifted out of Africa to one of 2 hospitals, one in Montreal, and the Toronto Western is our site in Toronto for repatriation. So despite the large size of the outbreak in Africa, there's been fewer than 30 cases outside of Africa, mostly healthcare workers, and mostly evacuated in a controlled manner back to their home country and to a specific facility. So that wouldn't involve Mount Sinai or St. Michael's, although we're a referral center. We're not a referral center for the healthcare workers that get sick in Africa. There have been a smaller number of patients who have been just diagnosed outside Africa. So in actual fact, I believe there's only 2 who were kind of walked off the plane and got sick. So there was the person from Texas who was going to visit family and friends in Texas, who was from Liberia, and there was the more recent healthcare worker who came back but was self-monitoring in his apartment and then presented as soon as he had symptoms. So really only 2 cases globally where somebody got off a plane and got sick. And so that's pretty low risk when you think about it across, like the chance of one of those people coming to Sinai is exceedingly low. And then there were 3 other cases that were transmissions that were diagnosed outside. So there was the Spanish nurse, and then there were the 2 nurses in Texas. And again, it's worth emphasizing what happened in all 3 of those cases. So there were 2 common features in those cases. The first is that these were nurses that were caring for patients that ultimately died of Ebola, and they were caring for them towards the end of their life. So I believe the Spanish nurse actually was only in the room twice, but they were doing extremely high-risk activities. So she was cleaning up diarrhea and vomit shortly before he died, and then she was in and dealing with the body after he died. And on top of that, so that was one theme, is that they're caring for people towards the end of life and when there's heavy contamination of the patient's immediate environment. Similarly, in Texas, you've all heard the story that he went to the hospital, he was assessed in the ED, he was assessed at triage without any, as far as I know, either no PPE or just whatever PPE you would normally use for any patient, and had abdominal pain, and they may or may not have recognized the fever, and the travel history and everything got mixed up, but they sent him home back to his family where he lived with 7 other people. And then he came back to the hospital, then he was assessed in the ED again, and at some point they drew the connection with Africa and Liberia and put him in precautions. None of those people got sick, so none of his family members, none of the ED staff. And again, it was the nurses who were caring for him when he was sicker, more towards the end of life. So putting all that together, I think where we're at in Ontario is that we all need to be prepared, but we also need to be calm and mitigate anxiety that's developing around Ebola. So a few things that are very apparent is that there's 0 risk to the general public. So there's no risk whatsoever, in my opinion, to the general public. I'm not particularly concerned. We get a lot of questions. What if they're in the waiting room? What if they sat in 3 different chairs? I'm really not worried about that. I'm not even particularly worried about triage, but I think it's always a good idea to take certain precautions at triage, because we see all kinds of people with all kinds of different problems, right? But we need good routine practices at triage, and we also have directives and things that we have to follow. So I'm not belittling what needs to be done at triage, but I think there's a little bit of room for error there. There's no room for error in taking a travel history. So the 2 ways that we could go very wrong is to not get the travel history and admit somebody to the hospital from one of these areas and have them traveling through the hospital here for a month, and then, or not a month because that wouldn't make sense, but they develop a fever and we think they acquired it in the hospital, and so we just missed the boat, like the Texas hospital. That would be one risk. And the other risk is not being prepared to care for somebody appropriately when they are very sick with confirmed Ebola. But we now have a system in Ontario with these 10 referral hospitals across the province, so they're busy preparing to deal with that kind of confirmed case where they would be very, very sick. So again, with a real Ebola patient, if they come in early, and again, all bets are off, but since they're unlikely to actually see one, the most likely one that we will see would be a typical one. If they've just come off the plane and then they come in right away, which is what you'd think people would do, they're going to have fever and a headache, but they're going to be wearing their suit and sitting in the waiting room saying, I'm a little concerned because I was working in a hospital in Sierra Leone, and I've been back for 3 days and now I have a fever. And hopefully if they're healthcare workers, they would have even called ahead and gone to the right facility. So all that to say that I think any individual institution in Ontario has a minuscule chance of seeing an Ebola patient, but we all need to be prepared and to think about it. And just one other thing along those lines that people often don't realize, because again, I get a lot of questions about what if there's a lot of patients and how will we manage that? But at the US network of their specialized infectious disease hospitals, where they seem to be planning to care for most patients, last I heard, their capacity is something like 9 beds. So across the whole US, they're not planning to have more than 9 patients at once, and we're 10 times smaller, so we need to prepare for about half a patient. So I'll stop there and just ask if there's any questions about that.
So I have a question. You and I have communicated around spacing at triage.
Yeah.
And I've seen both 1 meter and 2 meters quoted as standard spacing. And the public health people just submitted the same document we were working on.
Yeah.
And they quoted 1 meter.
Yeah.
And you quoted 2. So can you comment on the
Sure.
controversy and
Yeah,
sort of...
absolutely. I think the basic principle is that because it's spread by blood or body fluids, and I just emphasize there's lots of things about Ebola that get people confused. So on the one hand, it's an extremely severe disease, but then we say, but it's not transmissible. So a lot of people associate those two things as being linked, and they're not linked. So similarly, the blood and body fluids of somebody with Ebola are highly infectious. So it's not that's not, when they're very sick, not when they're asymptomatic and probably not very early in the illness. So, but their respiratory secretions and their droplets and then are not likely as infectious, and then there's not really airborne transmission. So without airborne transmission, if you're on a plane with somebody and they have a Ebola in row 1 and you're in row 20, there's just no possible way for you to get Ebola. It can't happen. It's just not possible, right? If you're beside them, they're still saying it's extremely unlikely low risk because probably they're feeling pretty well if they let them on the plane. They don't have a fever. So you're probably low risk beside them. But if for some reason they got on the plane late in their illness and they were vomiting and everything, it still would just be the people on either side who might be at risk and get sick. So the 3 feet, 6 feet, 1 meter, 2 meter is historic. So in old infection control principles before SARS said that droplets settle within about 3 feet. So from studies of, again, flu patients on airplanes and in other settings, that people within 3 feet get sick and people further than 3 feet don't get sick. In SARS, there was clearly transmission beyond 3 feet, sometimes associated with what we call sometimes aerosol generating procedures, but some of these procedures don't generate true aerosols like TB, but they just extend the distance that droplets might travel. And so it was felt that 6 feet was now the margin of safety in that context. I think neither of them really apply in any way to Ebola, but the idea is if you're sitting there and they can't vomit on you, then you're probably okay. So if there's a physical barrier between you, or a distance that's appropriate, then you're probably going to be okay. And yeah, so that's where it comes from. So there's probably not a really good reason for picking one or the other. Yeah. You go here. Why don't you?
So it sounds like this is not going to be like SARS, where we're going to declare it's over. What's the current thinking about whether this West Africa travel history becomes sort of the new normal? Like, we'll be asking it for the next decades.
I don't think it will go on for decades, I really hope, but certainly the WHO has indicated that there's no real possibility for the outbreak to end in the next 6 months. So this is going to go on for at least 6 months, and I think there's hope that with increasing international assistance to the area that it might be controlled in the frame of a year or hopefully less than 2 years. So that will, hopefully this situation will be dealt with. But there are periodically Ebola outbreaks. Ebola is not the only viral hemorrhagic fever. So there are viral hemorrhagic fevers that occur in South America, so closer to home. Lassa fever can occur in different places. And there are other travel-related illnesses. So I do think that it appears to be the new norm that a travel history is extremely important. So we still have MERS-CoV going on in the Middle East, which doesn't get talked about very much. There's way more travel between Saudi Arabia and Toronto than there is between any of those 3 countries that I mentioned. Incidentally, why was he in Texas? There's a large Liberian community in his area of Texas, right? So I've been asking around, and there's people in Toronto from everywhere, but I haven't been able to confirm that we have any sizable group from those 3 areas. So, yeah, so they tend to, when you travel from those areas, you go where you want to know somebody usually, right? So that's one answer. And then there's bird flu and whatever is going to come next. So I think a travel history probably should be the new normal.
In the media, they had spoken about the healthcare workers who were secondary transmissions, that they had potentially all 3 at some point touched their face while doffing the PPE.
Yeah.
But I don't know if that was confirmed or not. Do you know if that's been like another common thread with those 3 workers?
Yeah, so again, I know unfortunately through the media, so I haven't seen a lot of published data looking at those cases, but apparently the Spanish nurse said that she had touched her face, and clearly that would be a risk factor. And it sounded like she did that with like a gloved hand onto a face that was no longer protected. So that's obviously how we fear that people would get it. So absolutely, I think in your education and training around the use of the PPE, there's a complex protocol for putting things on and putting things off. But the critical thing is not to take contaminated gloves with blood on them and ever touch your face or any of the PPE on your face when you're in the room, right? So you'd want to really avoid adjusting goggles, face shields, your own glasses, or reaching up here in any way until you've removed your gloves and performed hand hygiene. And that seems to be a key principle. In the Texas hospital, from what I've been gathering, many things appear to have gone wrong. So there was, and it's unclear as of yet which one was the culprit, and may not be known, but they even sent the specimen through the pneumatic tube, right? So that's the first thing our lab did as soon as they heard about Ebola, is put big, huge signs everywhere saying, send nothing through the pneumatic tube. So they seem to do everything wrong at that hospital for whatever reason.
Yeah, because I'm doing training with the nurses upstairs on donning and doffing the PPE, and there's a lot of anxiety around, like, you know, even though you look well covered, you know, there's like, you know, what if, you know, it's just dangling on this side, and then when you're taking it off, like, what if you potentially your hair touched that, and then your hair's here, and like, I don't think that any of our PPE systems are going to be like perfectly foolproof, and so I've just been trying to ease that anxiety in them and just saying, you know, maybe there's a possibility that this centimeter, that millimeter might get projectile vomiting. But in fact, I think the biggest risk to you is that if you accidentally touch your face, that's going to be the biggest problem. So I don't know.
Yeah, it's a tricky one. So on the one hand, I'm trying to reassure people, because I think the chance of any individual healthcare worker caring for somebody with Ebola in Canada is vanishingly low. Just to be clear, I think if this does go on for a year or two, it becomes almost certain that Canada will have a case, right? Or maybe a couple of cases. But those cases are most likely going to get sick in Africa and be healthcare workers who will come to the Western or to go to Montreal. And then there's a much smaller case that will have this kind of walk-in, of which there's only been, there's 8 billion people in the world, and there's been 2 people that have gotten off a plane. So 1 in 4 billion chance right now of seeing somebody who just gets off a plane, right? And in medicine, we often accept risks of like 1 in a million and say, we're not going to worry about that at all. So just to put it in perspective. But on the other hand, once you're there and you're caring for a confirmed case of Ebola, that's not a zero risk situation for anybody, right? I think we have to acknowledge that. It's not a zero risk. And the critical thing is training and retraining. And I think one way that hopefully helps our system being able to do that is the people that need to be retrained and are the group that are going to be most likely to care for the patient. So the Western has been training for some time because they were designated before St. Mike's and Sunnybrook were designated. We've started training. We're also trying to, in our facility, identify an Ebola care team, so that even within our group, we're going to train everybody in the ED at least once, but we're hoping to identify a team primarily from the ICU that will travel to care for the patient, so it'll be a limited number of people, and they're going to be trained and retrained to be very comfortable with the PPE. But I think you're right, like we want the whole body covered, we do all these things, but I still don't actually really understand that if you got Ebola on your knee, how you would ever get sick, right? Unless there's a break in the skin. It's really, the way you would get sick is by then rubbing it with your hand and touching your eye. It has to come in through a mucous membrane or a break in the skin. But obviously we don't want you to get Ebola on your knee. But people are so anxious that they leap forward many leaps and bounds. And so the PPE that almost all of us are recommending now is, again, designed and intended for that situation where they're vomiting all over. So we're looking at the worst case scenario. But somebody with Ebola with a headache who's standing there talking to you and sitting in a chair, and you say, can you please come over to room 17, and they walk over to room 17, you can't really get Ebola from that person. And if you're going to take their temperature and so forth, you probably should be wearing gown, gloves, mask, but you don't need all of this gear, right? And everyone says, well, what if they suddenly turn the corner and vomit right then and there? So it rarely, when you actually ask people how often that's happened, some people tell me that's happened to them. It's never happened to me, but
I use the analogy to HIV/AIDS because we deal with that all the time, right?
Yeah.
And taking blood from or dealing with a GI bleed in a confused HIV patient is very different than triaging. I mean, we triage these people all the time, right?
Yeah, absolutely. So I think the PPE that we're all prescribing should be good enough. And there's common sense things too, like tie your hair back, take off all your jewelry, wear scrubs, put on your PPE. They can minimize the risk of anything happening. And I do agree that when you're caring for that high-risk patient, the critical thing is probably the doffing and needs to be done carefully. And then the other point of it too is if you do get contaminated, like somebody vomits on you, you wouldn't continue in the room for an hour providing care, but you would immediately leave before it does get all over. So I think a lot of common sense will significantly reduce the risk. And although people have probably heard about a number of healthcare workers in Africa getting sick, it is too many people. It's a lot of people going over there and getting sick. It's actually a very small proportion of the people who are working in Africa. So even in Africa, where you're much more likely to get sick for many, many reasons, right? So there's stories of one physician looking after 60 patients and they all have Ebola, and there's lack of PPE, and they're reusing things and having to, they wear these rubber boots, but the boots have to be cleaned and disinfected. They don't have the luxury of single use for all this stuff. So there's many, many reasons that they're put at increased risk. And one statistic, I can't confirm this, but I was told by one person that 13% of the healthcare workers in Africa who have acquired Ebola have acquired it outside of the hospital. So from helping somebody on the street or from somebody in their family. And so none of that applies to care in North America. So even there, when they use the PPE that's recommended by WHO or Doctors Without Borders, they provide care for many, many Ebola patients. And unfortunately, healthcare workers do get sick there, but it's still most people who go to help, they help, they come back and they never get Ebola. So it's still, you have to look at we look a lot at the numerator, and those cases are very dramatic for us as healthcare workers to think about, but nobody talks about the denominator, right? And if you talk to Rob Fowler, he's cared for hundreds of Ebola patients effectively and come back and forth to Sunnybrook without ever getting sick. And that's the more typical course, right? And once in a while you hear about somebody that's getting sick.
Can you comment on intubation? One of the directives is that you should wear, so far, it may be changed this week, I'm hoping, but it currently says you must wear PAPRs for intubation. And of course, that would require every emergency department in Ontario to train their staff in the use of PAPRs, because a suspect case could require intubation before they were cleared.
Yeah.
Right?
Yeah.
And I haven't seen any justification for it. I understand that PAPRs for prolonged bedside care of an end-stage Ebola patient might be more comfortable than standard PPE.
Yeah.
But the idea that you need PAPRs for intubation, would you comment on?
Sure. I'm going to comment on two things, because one I think is probably more important than the PAPR thing, but I'll do the PAPRs first. So right now PAPRs is part of the ministry directive that was from October 17th, and there is going to be a new ministry directive next week, so we don't know what they will contain, but we know that it's coming. I don't even really want to speculate on what's in there, what they'll change and what they won't change. So I don't know if we'll be stuck with PAPRs or not, but I think intubation could be done without a PAPR. And my understanding is that N95 is what you need for intubation, and that a PAPR is considered equivalent to the N95, so that we don't necessarily need to favor one over the other. But we have to look at
The one piece?
No. So all a PAPR is at its basic level is a sort of it's more for respiratory diseases like SARS. So it's a headpiece that provides ventilation, and then a belt unit with a sort of a hose that goes up there and it ventilates into you. But of course that won't protect you at all. So what you need then is PPE that covers it. So there's a hood. Similar to the hoods that you're probably using here, but designed to fit and integrate with the PAPR itself. And then it's compatible either with a one piece or with any other PPE, and you have to make sure it fits, but you could do it with a gown and the way that you're doing things here. So the PAPR is really the idea of that you have a hood and it provides ventilation inside the hood. So again, if you're in the room for 4 hours with an N95 mask and all this stuff on, you'll overheat, and it could be dangerous for healthcare workers to do that. So actually one recommendation is that you shouldn't be in the room for more than an hour caring for somebody with Ebola. So that solves that problem to a certain extent. But people do find that the ventilation with the PAPR is more comfortable. It says it's blowing cool air, and you have your space hood on sort of thing with the cool air flowing inside, and no need for the N95 mask or goggles. So that's the advantage of the PAPR, but it's not necessarily safer. And in fact, there's challenges of getting the PAPR off, and it can't be done by one person. So whereas we advocate for a buddy system, what we're advocating at St. Mike's is you have a buddy who's observing you remove PPE, not necessarily physically assisting you, right? Which just adds another layer of complexity. So with the PAPR, you probably need somebody to physically assist you in the removal process. So it just adds another level of complexity there. And certainly you'd want to be very well trained to use a PAPR. I don't think it's super hard to figure out how to use a PAPR just for fun, but to use it and remove it properly would require a lot of training. So we'll have to wait and see. But the one thing I think that you made a very good point is, although I've been emphasizing the unlikely nature that any one of you will ever care for an Ebola patient, there's a higher probability that you'll care for a suspected Ebola patient. And so this is one of the big challenges. And I think the most important thing that we need to do as health professionals who have expertise in Ebola is to really draw the line when you see a person who doesn't even have suspect Ebola. So there's so much anxiety around that I've heard all kinds of stories of basically Ebola precautions being initiated because the person was from Nigeria even after there were no cases in Nigeria. Or even when there were cases in Nigeria, it was only 2 parts of Nigeria, so they were from an unaffected part of Nigeria, and there only ever were 18 cases in Nigeria in a population of 180 million. So there was really no need to worry about those people. Somebody from Senegal, when there was 1 case in Senegal, and also after it was cleared from Senegal anyways, somebody who looked African and was unable to give a travel history. So we need to step up and say, if somebody who can't give a travel history doesn't have Ebola, it doesn't make sense logically. Like logically they could have Ebola, but the risk of them having Ebola to begin with was so low that the fact that they can't give a travel history should, in my opinion, mean that Ebola is now excluded, unless they have their Liberian passport sort of stapled with the date of their travel ticket or something. That, so we need to say, somebody who came, I got a call about somebody who arrived from Nigeria 6 months ago, and could they do an ENT procedure on them? So when you see people like that, you have to just say, this person has not have Ebola. You can go in the room, wash your hands, and go take care of the patient. Like, you don't need any PPE, because once you label them as suspect, so suspect means they might end up being confirmed. That's what it's supposed to mean. But the risk of a suspect patient is still of having Ebola is still much lower than the risk that they have something else. But we do have to draw some line in the sand. And the reality is, once you label somebody as suspect, you're more or less going to need to treat them like a confirmed case, right? That's the basic principle of how this would work. So if you label somebody suspect when you don't need to, you're going to significantly impede their access to medical care and their probable outcomes. So that's one thing. So whenever we have the opportunity of confirming the history, double checking the date, making sure, and if and saying, no, that was 37 days ago, and the fever just started today, that this is probably something else, that's really, really important. And then when we do have suspect cases, I think we have to think before we make general decisions and say, we're not going to intubate anybody with Ebola, is that you have to take a step back and think, most of these people are young, healthy Canadians with a reversible illness that could be easily managed if they hadn't been labeled in this fashion. So I think that's a really important thing. So most of them have malaria or flu or whatever they're going to turn out to have, or even they're having an MI and they happen to have come from Liberia and spiked 1 temp or something. So we have to put processes in place that are not completely unreasonable for the harm that could be done. And so Canadians are already being harmed by Ebola indirectly by having longer times to accessing care. And there's other stories I could tell. They sent somebody in an ambulance with query meningitis from one hospital 4 hours over to the other because they didn't want to do the LP or have anything to do with them. And so these things are actually happening all across Canada.
When we take the travel history, we know the countries involved, but as far as someone being from, like the case you mentioned in Nigeria, but from a different region, Are we now discussing the possible positive suspected case with our microbiology team, or are we looking it up on the CDC website, or what do we do with that travel
So
history?
I'm going to tell you what's happening at St. Mike's, and then Wayne can jump in if Sinai is a little bit different. So in all of our ambulatory areas that are screening, plus our ED, we have signage posted for patients to come forward if they have fever and a travel history. Especially outside the ED, it's very general. It doesn't ask them where they traveled. We didn't want to stigmatize anybody. And then we have people trained at the reception areas, and particularly at triage, with the flow diagram and the questions that they should be asking, and the specific country. So it says Liberia, Sierra Leone, Guinea. Those are the only 3 we're worried about right now. And so we say, if they say they've traveled outside Canada in the 21 or 30-day time period, depending what you're doing, then ask them where they traveled, and if it's one of these countries, then do they have a fever? So that's the algorithm that we're using. So it doesn't require, at the point of the triage person calling microbiology or anything else, up to the point where they've now identified that they have a positive travel history. So once you say, yeah, they came from Liberia 3 days ago and they're feeling feverish, then we say, okay, we're going to go to room 10, and they're going to tell the MD, the senior MD in the ED, and they're going to contact infection control, and we're going to then review the situation and get a second person to go in and confirm those details. So again, the instructions are fairly simple, but it is possible for people to be anxious. So another one we had at St. Mike's was somebody got put in precautions, and then we went down, what they said was, he came from Seton House and his friend is Nigerian. So, and so what if his friend had Ebola and this kind of thing? But his friend wasn't even sick. So you do need to confirm, so you
So if I'm the second person, and I go in and confirm the detailed travel history after they've already triaged positive screening, then is our degree of travel history just coming from one of those 3 countries, irregardless of region? Like, it's like, if you're from that country, you are...
Yeah, I think you could get into nuances, but most of Liberia is now affected. So there's actually very little of Liberia that isn't affected. In Guinea, it's a bit more patchy, but it's like half the country. So I think I think we would look bad if you had somebody from Guinea with a fever and you didn't treat them as an Ebola case. And later on, when they turn out not to have Ebola, you may recognize that they came from this part of Guinea that's probably not that infected. But the information, the health systems in these countries have largely collapsed to a certain extent. I think data is unreliable. So for those 3 countries, absolutely. But right now, as I said, I would not worry about anyone coming from Mali, despite this one case. But unfortunately, if they start to see more and more cases, the first thing that will happen is it will become like Nigeria, likely, where they said, okay, in Port Harcourt, there were cases, but not, and in Lagos, but not anywhere else. So there might be a phase where there's a part of Mali that's high risk and a part of Mali that's 0 risk. And your infection control department should be liaising with triage and other areas, and not, posting on your intranet and so forth. Like, these are the areas that are involved.
Okay.
Yeah.
So our 2 microbiologists are happy to be called stat 24/7 to help you make that decision. And so, especially if you're busy, I'm not saying that it's rocket science to figure that out, but if it's not obviously cleared, I think it would be more comfortable to discuss it with somebody else who's dealing with this every day and have 2 heads, say, yes, it's cleared.
Right. And on the other hand, it's a fairly straightforward travel history. Like,
Yeah,
you've been to these
where
3
were
countries,
you?
where you haven't.
Where did you
Right.
go?
Yeah.
When
Yeah.
were you there?
Yeah.
What did you do there?
Okay.
So why do we call microbiology instead of infectious disease?
There's probably a few
Well,
reasons.
There's 2 staff
Yeah.
instead of a junior.
Yeah. At my facility, you would call infection control, which is me or sometimes one other person, and then the infection preventionist. So it's infection control that helps make the decision, and we're relying on infectious disease more if you have a fever in a traveler and you want to know what's the differential. Maybe they also have malaria and they need to be treated for malaria. But our microbiologists want to be involved early as well, because there are issues with testing. And so they should be, no matter whether you're going to get them involved in deciding whether it's a real case or not, they're the ones who get involved for safe processing of the specimens. And again, because it's a bloodborne illness, there are issues in how the specimens are collected, transported, and managed in the lab that have to be done safely. And so for the same reasons, they don't want to, it's going to disrupt their lab, so they also don't want to test people for Ebola when there's really no need to do that, right? And once you test them, then right now you're waiting 48 hours to get a result. And so usually the principle is, once you think somebody has Ebola to the point that you've tested them, you can't not treat them like an Ebola patient until you get those test results back. So the microbiologists want to make sure that they did travel, they do have a fever, and that kind of thing. But your microbiologists, I think, are perhaps helping also cover in infection control, so they're kind of wearing more than one hat here right now.
But again, there's 2 staff people. We can't control the call schedule on ID. You often get a junior on ID who says, I'll call the fellow. Whereas if you call Sue or Tony, you'll get Sue or Tony. Again, they won't give you a comprehensive consult on what's wrong with my patient, but they will discuss with you whether it could be Ebola or not, and if there's any doubt, they will come to the emerge. They'll page one of the infection control practitioners to meet them there, and they will assist us in taking the specimens, getting them tested if that needs to be done, etc. So don't make it up. Just do what we ask you. Just call the microbiologists. They're all ready to go, and they will know what to do. Any other questions?
Great. Thank you very much.
Thanks a million, Matt.
Thanks, Rick.